Welcome, everybody, to the Cone of Shame Veterinary Podcast. I am your host, Dr. Andy Roark. Guys, I got a Halloween episode for you. Dr. Harry Cridge is here. He is a veterinary internal medicine specialist, and he is joining me today to talk about maybe why we shouldn't be so afraid of pancreatitis. We're talking about pancreatitis panics today. We're talking about the horror stories of how pancreatitis cases go wrong and what's real and what's not. We are talking about common pitfalls in the treatment of the condition, how to effectively work these cases up, and finally, how the new drug PANOQUELL CA1 works in these cases. Guys, quick, to the point, super useful, and one less thing to be terrified of. Guys, let's get into this episode, but before we do, I just gotta stop real quick and say thank you to CEVA Animal Health for making this episode possible ad-free. Guys, let's get into it.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. Andy Roark.
Welcome to the podcast, Dr. Henry Cridge. Thanks for being here.
Yeah, thank you for having me.
Oh, it is my pleasure. So for those who do not know you, you are on the faculty at the College of Veterinary Medicine at Michigan State. You are a boarded veterinary internist, and you are a researcher, and your research focus is in disorders of the pancreas. And so I wanted to have you on today to talk with me a little bit about the scariest part of the abdomen in my mind, which is the pancreas, which is where, when you make it mad, bad things happen. And I want to ask you, here's what I'm looking for you. I want a little bit of comfort in my treatment of pancreatic disease and illness. And it's in my mind, the pancreas is kind of this glowing red button that I really don't want to press. And so I want to talk to you in realistic terms. I just want to start at a high view about sort of pancreatic disease and illness. And I wanted to sort of ask you about what are the most sort of common pitfalls that we make in treating pancreatic disease. And let's just start there. So it's a sort of a scary thing for me. And so let's just start at how much is a risk and what are the most common risks?
Yeah, so I think in order to effectively talk about treatment of pancreatitis, we really have to think about how we diagnose the disorder and sort of what our goals are, and that may vary dependent on the clinical situation you're in. Historically, people used to use pancreatic biopsies, but we all know that they have significant limitations. They're invasive, they're costly,
they're terrifying.
Yes, and
they're terrifying.
Not good anesthetic candidates. So we've fortunately largely moved away from that for that very terrifying reason.
Okay.
But it does put us in a position where we're now reliant on an overall assessment of the clinical data that we have. That may be the patient history, it may be the signalment, and it may be the results of imaging and pancreatic lipase assays. And we ourselves then become the gold standard. And while that's fantastic for us and fantastic for job security, we do need to be very aware of some of the limitations of some of these diagnostics so that we can accurately interpret them and do the best by the patient.
Okay, let's drill into this a little bit. So I'm intrigued here. So I like your idea. The pancreatic biopsy is generally, I am not doing those, and so it makes me feel good that that's not sort of accepted standard, and we've kind of moved past that. Talk to me about the limitations in the standard tools. So my impression with pancreatitis is, I kind of do some voodoo. I think most veterinarians sort of do. I look at the patient. I'm feeling the abdomen. I'm looking for clinical signs. I'm looking for obvious pain or discomfort. I'm looking for the general dumpiness. I think that's a clinical term is dumpiness. Yeah. I'm looking at the general dumpiness of that. I'm looking at the blood work and I'm kind of squinting at the lipase and I know that that's not I know that probably, I don't know how much that means exactly. I tend to take it with a grain of salt, but I'm definitely looking at amylase, lipase, things like that. I'm going, and then my pancreatic lipase, snap test, things like that. But even then I still know that there's a big range of what is what is clinical and maybe what is diagnostic. And so anyway, can you sort of flesh out in sort of more specific terms what you mean when you say, we have to be careful in making a diagnosis here, and there are shortcomings in how we do this?
Yeah. So I think, as veterinarians, we have to sort of think ultimately, what is the purpose of the test that we perform? And, in a case where we have a patient that's, clinically unwell, has cranial abdominal pain, and we're suspicious for pancreatitis, then, the question becomes, what do we have to rule out in order to not change how we treat this patient?
Okay.
And in those cases, we may get away with, limited blood work, some level of pancreatic lipase assessment, and, a radiograph to rule out the foreign body that we don't want to miss. So practically, that may be what we need in a first-time offender with, no other complications. But that patient that's not getting better, or that patient that keeps coming back, that's probably a case where we need to be a little bit more solid in our diagnosis to make sure we're treating the right thing.
Okay.
And I suppose that's where we have to look a little bit more closely at the limitations of each of the diagnostic tests we have. And you mentioned a few of those diagnostics, predominantly blood work biomarkers, lipase, amylase, and pancreatic lipase. And what I like to encourage people to think about with those particular assays is, lipase and amylase, they can come from multiple different tissues. And why that matters to us as clinicians is, if they're elevated, we can't say for sure that it's coming from the pancreas. It could be coming from another organ system, or it could be not getting excreted properly, the problem with the kidneys or something else. So we try to find an assay that is the most specific to lipase from the pancreas. And the hope there is, if that's elevated, the pancreas is inflamed, the pancreas is annoyed. So we try and pick a more specific test. Out of those tests, the pancreatic specific lipase, or the quantitative test that often gets sent out to the lab, is going to be the most specific one, the one that we can put most, strength in our diagnosis behind. But we do also have to be aware that there are other diseases outside of the pancreas that can also irritate the pancreas. We know for a fact that, if the abdomen is angry, the pancreas is also angry. So just having the elevated lipase on its own is not going to be enough. We need to still do imaging and look at all that data together. And that's why we run into some challenges is we can't rely on a single test. So it can be challenging to get all those diagnostics and convince our owners to do those. But the cases that probably need that the most are those cases that keep coming back, or those cases that aren't responding to standard of care therapy. Talk
to me a little bit about your perspective on ultrasound as a diagnostic tool in pancreatitis. How much value is that over radiography just to rule out foreign bodies? Can you just weigh in a little bit on that, because you haven't mentioned it as a diagnostic tool?
Yeah, so I think those lipase assays have to be combined with some level of imaging. Ultrasound is the one that's most classically used. And ultrasound is very valuable in the fact that we can really see if there are any changes to the pancreas consistent with pancreatitis, but also we can help rule out other, abdominal disorders that could cause similar clinical signs. One of the times that we run into some challenges with ultrasound is there's been a few studies recently that have looked at those cases that you may have seen in practice, where you finally convince the owner to do the lipase test, the ultrasound, and you think you're doing a great job, and then all of a sudden, all your test results disagree with each other. And you're like, well, what do I do now? And that patient population certainly does exist.
Yeah.
We're getting more data out now to try and explain why those discrepancies are occurring. And I think one of the things we have to think about is, these are biomarkers of disease, and each biomarker of disease or each imaging finding takes a certain amount of time to develop and a certain amount of time to disappear. And the preliminary data that we have is that any of the biomarkers of inflammation, so pancreatic lipase or C-reactive protein, any of those inflammatory type of biomarkers have relatively short half-lives. So they're going to go up relatively quickly after an injury to the pancreas, but they're also going to fall off relatively quickly, with most data out now saying that within 2 days of diagnosis of pancreatitis, that pancreatic lipase is going to return to within the reference interval, whereas ultrasound changes may persist for longer. So when we're taking a single time point in these cases, we don't know where exactly on the upswing or the downswing of those lipase markers or the ultrasound we're going to be, and that's when discrepancies can occur. So the way that we are trying to work on that in practice is, thinking about these tests as more dynamic than we, originally did. I think we used to say, okay, we've got my diagnosis, we're good to go. But those cases where there are discrepancies, they're probably cases where we need to do, either repeat imaging or repeat lipase or repeat SNP test to see how things are changing over time. And that can help further solidify that diagnosis. So thinking about the half-life of some of these tests and thinking about, okay, if they disagree, let's get another time point and see, which direction are we moving? And are we moving towards agreement and it was a very relatively recent injury? Or are we getting further apart and it was probably a past pancreatic injury?
When you think about gastroenteritis, pancreatitis, do you see sort of levels of disease, or do you look at is there a mild pancreatitis in your mind, or are they always to be sort of worked up the same way? Talk to me sort of about severity in the disease as you see it.
Yeah, so there's certainly, fairly substantial variations in the degree that an animal is, whether they're clinically affected by pancreatitis or not. At the referral level, we get a lot of the severe pancreatitis cases, the one that causes the most, stress, but also the most fun. But there are a lot of cases that, in practice where, you can make the diagnosis and sometimes treat them, on an outpatient basis. And we'll touch on that a little bit later when we talk about treatment options. But yeah, there's certainly a big spread. And I think there's probably the fact that some animals have chronic disease that we under-recognize, and they have an acute on chronic flare, and they typically are a little bit more mild, at least in my opinion, versus, the first time really severe acute disease.
What do those acute on chronic cases look like to you? I mean, how do I not look at this and go, well, this is acute pancreatitis? What should I be looking for if I'm trying to catch on to that? Is it just that I've seen this patient before, or
I think it's, twofold. One is, if that patient keeps coming back and, keeps getting diagnosed with pancreatitis, I think the likelihood of these being, independent events, specifically if they're in short succession, is probably lower. And it's probably had some level of chronic, perhaps subclinical inflammation going in the pancreas between flare-ups. And then the other thing is, ultimately, a lot of these patients come in on an emergent basis. So we're all focused on stabilizing these patients and getting them to where they need to be. But when we, take a step back and think about asking more detailed questions, often these animals will have more substantial GI histories than are initially reported. And we actually found that in a study we did relatively recently, I think last year. We took, several hundred dogs that had elevated pancreatic lipase concentrations, and we surveyed and looked at, clinical presentation of these dogs, what risk factors for disease they had, and also how many of them had past episodes of GI disease. And it was a significant number of them that had these chronic GI histories that perhaps go, under-recognized on first glance.
That makes sense. It's funny. I love that you called out sort of emergency cases where they show up and you're the emergency doctor and you have no idea what, what the rest of their file looks like. And I think about cases I've seen, and you kind of look at this patient, especially if it's, a 10, 12-year-old dog that's kind of had GI upset, diarrhea, things like that throughout its year. It's easy to kind of just gloss over that and not really say, hey, is this something that's related to what we're dealing with today? And so that's a arrow I'm going to put in my quiver. I need to start looking for the chronicity of that. So anyway, I love that you say that. How do you start to, let me just ask you this again, because I said this is sort of a fear episode for me. What mistakes do you see as people start to address these and decide how they're going to treat these cases? Do you see, I don't know, do people tend to be less aggressive than they need to be? Or are there tricks that you say, oh man, I don't know why doctors consistently, don't do this? Or talk to me a little bit about how people struggle to treat these cases.
Yeah, and I think this sort of touches on both diagnosis and treatment. In terms of diagnosis, there was some common pitfalls, and again, I don't always think that these are the fault of the veterinarian. It's often the situation you're in and the finances that you have available to you. But there are a lot of cases where clinical signs and an abnormal SNP test, it's not a guarantee of a diagnosis of pancreatitis. There's a lot of or the diseases where, it's either a false positive test, which is proposed in the literature, or this animal has some level of pancreatitis, but it's secondary to whatever else is going on. So relying on just the SNAP test is probably not great, particularly in cases that are recurrent. Other things that, we sometimes see is, those patients that keep coming back. We're all really, really good at managing those acute pancreatitis cases. We get them on fluids when we can. We treat them with pain medications as we can, and we get them better. But I think one of the things we sometimes, don't put as much time into is thinking about, are there any identifiable risk factors to prevent this animal keep coming back? So in those patients, measuring a triglyceride concentration, looking to see if they've been on drugs that have been associated with pancreatitis in the past and whether they need to be on those drugs. Some of those common ones is, anti-seizure medications, and some of those, you of course can't come off, but it's worth looking at and thinking about, and especially screening for lipid disorders or endocrine diseases. They're the cases that when we identify those and treat those, my opinion is they've got a reduced chance of recurrence and reduced chance of coming back in with a severe disease again.
I like it. That makes sense. One of the new things this year that I've really seen a lot of discussion of is the PANOQUELL CA1 medication that just came out, is conditionally approved by the FDA. Can you talk a little bit about the role that you see in PANOQUELL CA1 playing in treatment of these patients?
Yeah, so as you mentioned, PANOQUELL CA1 is a new drug on the block, and there's a lot of excitement about it. I think there's a lot of excitement because for many, many years we've been restricted to just supportive and symptomatic care in these patients, and we all know from our own experiences or from the literature that as hard as we try, there's often a significant morbidity and mortality, especially with the severe cases. So having a new option is really exciting. I think it has got conditional approval, so over time they will need to work towards full approval. But it's really exciting to have a new and novel treatment on the block for these tough cases. The way that the drug works is it's a drug that acts on neutrophilic inflammation. So the way that inflammation is obviously strongly associated with pancreatitis. So the theory behind this drug is if we reduce the amount of neutrophils that come out of the blood vessels into the tissues, we're going to reduce the amount of inflammation, and therefore, help this patient. The way that it does that is it focuses on how those neutrophils come out of the vessels. So we think all the way back to vet school, we think about sort of the rolling, the activation, the adhesion and migration of neutrophils from the vessels into the tissues. And that PANOQUELL or the fusaplatinib acts on one of the key players in that. So the key player acts on is something called leukocyte function associated antigen 1, or LFA1. And that is a specific molecule that allows that neutrophil to subsequently extravasate. So that fusaplatinib blocks the activation of LFA1, which then prevents it from being able to go into the tissues. So it stops that neutrophil extravasation.
What's the impact if I catch this late, right? So I understand I understand the slowing down, reducing neutrophils coming out of the vessels. That makes sense to me. But it feels like if I inherit a pancreatitis case and everything is already flared up, am I still getting benefit from this medication?
Yeah, so I think, certainly what we know so far based on the studies that are out there is that it has been shown to improve the clinical signs associated with the acute onset of pancreatitis. And that was a fairly broad patient population that was used in those studies. We do, over time, I think we're going to work out when is going to be best to use this medication. But when we really think about it, there's a lot of these cases where, the degree of inflammation is what's causing the challenge. If you get in nice and early and prevent that severe neutrophilic inflammation, in theory, that would strongly benefit the case. And, there's a lot of utility in using this early in the course of disease. Later in the course of disease, of course, helping with any level of inflammation is going to be of benefit. It's just working out, how beneficial it may be in those particular cases.
That makes sense. Getting back to sort of our horror theme, what are the side effects? Are there contraindications that we're looking at, things like that?
The only sort of labeled contraindication is, don't give this drug to a dog that is allergic to the drug, which, is like a classic, and one that's, always on the label. So that's the only, labeled contraindication. As with any new drug that comes out, there's certain ways that we can look for adverse effects. One of those is to look at the safety studies, and one of that is to look at any adverse event that was reported in the efficacy studies. So when we look at the data, and that is available to anybody on the FDA website, the Freedom of Information Summary for the particular drug, you can look and see, what adverse events occurred in the patients that received the drug and what adverse events occurred in those that didn't receive the drug or those that received the placebo. A lot of the adverse events that were reported are, GI upset, some elevations in liver enzymes, and various other adverse effects. And any of those could be either from the underlying disease or from the drug administration. So that's why we try and look at, what happened in those that got the drug and what happened in those that didn't get the drug. And the other place we look is the target species safety data, again, which is publicly available to any veterinarian out there that wants to look at this data firsthand. And in those type of studies, what they do is they give the new drug and they give it at higher doses and for longer periods of time than is on the label, and they look to see what happens. So for fusilplatin or PANOQUELL, it's like a 5 times overdose, and they give it for 9 days instead of 3 days. And they look to see, what happened in those populations. A higher blood pressure was noted in those dogs on significantly high doses of the medication. And there was some injection site swelling in one dog, I believe, among some other adverse effects. So right now, it's hard to be 100% sure what's the drug and what's not, because a lot of the clinical signs that were reported are things that we see in pancreatitis. The dog that's vomiting, the dog that has nausea. So we can't definitively associate those with the drug. But as more and more people use the drug and more data comes out, I think we're going to have a much stronger idea of the specific nature of that drug.
Tell me about the route of administration and the time to effect. I mean, how do we get this on board? How long does it take before we start to see benefits?
Yeah, so that's a great question. So the drug is given once daily for 3 days, and it's given intravenously. In terms of what data has been used for the drug approval was the clinical improvement in the clinical score system by day 3, the end of the drug administration. But the next sort of question is, it's an injection. So how do I store that and what can I use it for? So it's a medication that comes as like a powder, a lyophilized drug, and it's mixed with a sterile diluent, and it's then stored in the fridge for up to 28 days. So once you have this drug in practice, you can store it for, up to 28 days. And it's a multi-dose vial. So it is really, really useful for, multiple patients.
Is there anything that says I have to give this intravenous injection to a hospitalized patient? I mean, sometimes I'm trying to help patients that they may have money constraints. Sometimes we have, sometimes we treat complicated cases on an outpatient basis. Anything that says I have to have the patient in hospital, does it need 24-hour monitoring, anything like that?
No, absolutely not. So the medication is, it's a once a day medication, and it is intravenously. But there's nothing specific about the drug that would mean that they would have to be hospitalized between those injections. So I know there's, a lot of cases in practice where we are treating these outpatient, whether it's a milder case or, financial limitations or, or frankly, the staffing available in the hospital to manage these as an inpatient. So I think it certainly has utility in outpatient management as well as inpatient management.
Awesome. Dr. Henry Cridge, thank you so much for being here. Thanks for making me feel safe about pancreatitis. I appreciate that. Are there any resources that you really like, anywhere that you would point people if they want to learn more?
Yeah, so the CEVA Connect website is really, really useful. They're putting a lot of really clinically relevant information about the drug on that website. They also have a dehydration wheel, which is designed for those veterinarians in practice where, you may not always have the amount of time to fully calculate fluids or you perhaps just want somebody to double check you. You can enter the patient's weight, the level of dehydration, and it'll tell you what sort of fluid rates might be appropriate for that particular patient. It's a lot of really useful things just for the general management of pancreatitis on there. We at Michigan State have put out a review article on pancreatitis in both the Journal of Veterinary Internal Medicine and JAVMA and the clinician's brief. So there's a lot of, publicly accessible data on how we treat these patients. And, at the end of the day, we'd love to hear, how other people treat these patients. The more we talk about pancreatitis and the more we learn from each other, the better chance we have of improving the outcome in these patients that, don't always have the same outcome that we would hope for.
No, that's amazing. I'll put links to all these resources down in the show notes. Everybody can check them out. Guys, I hope you'll take a look. Gang, thanks for being here and listening, everybody. Take care of yourselves.
Awesome. Thank you.
And that's it. That's what I got for you guys. I hope you'd enjoyed it. Thanks so much to Dr. Cridge for being here. Thanks to CEVA Animal Health for making this episode possible. I hope you learned something. I hope you're going to be able to put this to work so that maybe it makes your pancreatitis cases a little bit less scary. I know it will for me. Anyway, take care, everybody. Talk to you soon. Bye.